Now, there is a substantial evidence now that secondary prevention through comprehensive risk factor modification has lot of beneficial effect in patients with chronic coronary syndrome. And we all believe that if you are adherent to 4 cardioprotective medications, the 2-year mortality in ACS patient decreases from 10 to 2%. And all the guidelines, now almost all guidelines, global CSD management guidelines has recommended aggressive risk factor management with adherent to healthy lifestyle and cardioprotective therapies in all patients who has been diagnosed whether with ACS or chronic coronary syndrome. Now this is the actual things. Status of the secondary prevention is very poor worldwide. It is still poorer in developing countries and underdeveloped countries because of lot of other issues. There's 3 important studies, the WHO PREMISE study, EuroSphere study, the PURE study, and nationwide prescription audit, which is an Indian study. They all found a very low adherence to secondary preventive strategy in patients with chronic coronary syndrome. Now, what are the basic secondary prevention interventions? The first and foremost, we can say that you have to manage this disease. So management of the disease per se, patient education, multidisciplinary team-based lifestyle modification, pharmacological intervention, and the most important thing, risk factor and comorbidity management. So what are the lifestyle intervention we advocate in secondary prevention? The first is a physical activity, class 1 indication, smoking, cessation, class 1, alcohol moderation, class 2, healthy diet, yes, it is class 1 to 2 depending on various guidelines, which you have to reduce your trans fatty acid, reduce your saturated fat, increase your MUPA and PUFA, lead lot of complex carbohydrate, the weight management and cardiac rehabilitation. Physical activity by means of 3 things, enhance physical capacity, comorbid risk factor modification, and they improve quality of life, thus improve the symptoms and lot of other complications of chronic coronary syndrome. Disturbance or abnormal sleep duration, it has been recently included for secondary preventive strategy, and we all know that if there is a sleep disturbance, it has increased cardiovascular risk. And the most important risk factor which we all correlate is obstructive sleep apnea, though there is no hard data which shows that managing these obstructive sleep apnea will have a better CV outcome in patients with chronic coronary syndrome. Smoking and tobacco cessation, I think this is an absolute established fact that you have to stop this for secondary prevention strategy and improving your lifestyle. Alcohol, it's a controversial issue, but still no guideline recommend that you should prescribe alcohol. You should advise your patient to continue alcohol as a primary and secondary prevention strategy. Weight management, yes, obesity has a direct relation with coronary artery disease, comorbidity and morbidity and mortality. So we should maintain ideal weight from 23 to 27 with a waist circumference less than 80 in women and less than 90 in men. Dietary modification, a lot of debate. Eat low carbohydrate, eat low fat. But there's certain recommendation we all believe that you should avoid in all diet. You should encourage fruit, you should encourage vegetable, complex carbohydrate, stop your trans fatty acid, saturated fat, and eat more MUPA and FUFA, eat more fish, avoid sugar added, all the things. So these all guidelines, basically, if you go, they belong to these all small, there's a very small difference in all the guidelines. Yes, we should not say absolutely very low fat diet. This is, I think, this is a very wrong message we always give to our patient, that if you have a chronic coronary syndrome, you should stop eating fat. No, fat is very important for your body. Tell them, start eating good fat. Start eating more MUFA and PUFA. So very low fat diet, I don't think it's good for a heart. A low carbohydrate diet, yes. We all believe that if you decrease your carbohydrate content, especially the fine carbohydrate, it improves your weight gain and it also improves your glycemic index, thus may be beneficial for secondary prevention in chronic coronary syndrome. So I always say fats are not outcasts, eat good fat and don't stop fat, because if you decrease fat, you will increase your carbohydrate, and especially a simple carbohydrate which may be more harmful for the patients. And this is all the recent European guideline has suggested what are the healthy diet characteristics. Mental disorder, yes. All mental disorders are associated with the development of cardiovascular disease. And you all know that if you have a cardiovascular disease, if you have ACS or if a stable coronary artery disease, the mental illness increases by 2 to 3-fold. And there are some study which says that 50% of the patient in ACS or chronic coronary syndrome will have some form of mental disease. So now the mental, this has been included in classical CVD risk model. Non-alcoholic fatty liver disease is recently added. So if you have, try to decrease or try to improve it with your lifestyle modification. Then the drug therapy, the antiplatelet therapy, yes. These are the 4 drugs which are important in secondary prevention strategy, that is antiplatelet, statins, beta blocker and ACE inhibitors. Let us come to antiplatelet therapy. Antiplatelet therapy is the most important and shows the maximum benefit in acute coronary syndrome. However, the benefit in chronic stable coronary artery disease without any intervention is modest. We all believe that in post-ACS patient, you have to give dual antiplatelet for 12 months followed by a single antiplatelet. And the choice may be clopidogrel or aspirin. There's recent data which shows that you can continue clopidogrel, which is better than aspirin, but it will be your choice. No guideline compel you to give clopidogrel for a long term instead of aspirin. But for a stable coronary artery disease, without any intervention, you have no PCI, you have a stable coronary artery disease, I think nobody is going to recommend dual antiplatelet. Everybody will recommend single antiplatelet lifelong. And the choice is still the aspirin. And these are the guidelines which I have said, aspirin to all. If there's aspirin intolerance for clopidogrel, there is some debate that some people say that clopidogrel is better than aspirin, but there's no data in stable coronary artery disease to start with. Lipid lowering, I think there's no debate. This debate ends in lipid lowering, that all patients of chronic stable coronary artery disease should be given a high dose statin. And what is a high dose statin? We all believe that bringing the LDL, and this is a meta-analysis, we say that there's, if you decrease your lipid level by 1 millimole per liter, you decrease your event by 21%. And this is being repeatedly demonstrated. A recent trial of about 3 lakhs patients, 27 trial meta-analysis. Again, 1 millimole liter reduction, approximately vascular event is decreased by 17%. So statin are universally recommended. And what should be our target in chronic coronary syndrome? We all target less than 70. And ideally, some guidelines say that less than 50 should be the targeted, triglyceride less than 150, and lipoprotein A ideally less than 50. So if you are not able to achieve your target of 70 milligram by statin high dose, then you can add various azithromycin or bempedoic acid or monoclonal antibodies, PCSK9 or inclisiran. They should be added, but if you are able to achieve your less than 70 with high dose statin, I think I will prefer to continue high dose statin. But if you have a repeat, some guidelines suggest that on high dose statin, if you have a ACS, I think you should bring down your LDL cholesterol to 40 milligram. Triglyceride lowering, though there is no convincing data, but we all believe that we should keep our triglyceride to less than 150. Lipoprotein A, no randomized intervention study, but we all believe that less lipoprotein is beneficial in these patients. Beta blocker, yes. Beta blocker is a first-line cardioprotective agent for all patients with coronary artery disease, and the evidence is more for LV dysfunction. So now, and post-MI patients. So post-MI, it has definitely shown a mortality benefit, especially in LV dysfunction patients. ACE inhibitors, definite load, class 1 indication in all ACS or stable coronary artery disease patient who has an LV dysfunction. And these all our trial has suggested that even in high-risk patient of chronic stable coronary artery disease, you can prescribe ACE inhibitor lifelong. This is very important, management of diabetes and hypertension. So you should target your hypertension if you have a chronic coronary syndrome, 130 to 80, and your HbA1c should be less than 6.5. That is very, very important. So more emphasis on control of your comorbid conditions. Anti-inflammatory, yes. There is a recent evidence that monoclonal antibodies targeting canakinumab in CANTOS trial and colchicine in COLCAT and LOCODO-2 trial has shown benefits in ACS patients and especially the chronic stable patients, but is still not recommended in a guideline. But if you have a recurrent ACS, you can add colchicine or these patients, these drugs for management of secondary prevention. cardiac rehabilitation program. More and more emphasis is now given on cardiac rehabilitation program. Now this is the biggest problem, adherence to secondary preventive strategy. And all the data suggests that even in developed country, it is 50% who adhere to their therapy. So these are the various guidelines which suggest that if you have a patient with established ACVCD or you have a chronic coronary disease, you have to go by these lifestyle. Step 1, stop smoking, lifestyle recommendation, bring your systolic blood pressure less than 130, LDL cholesterol more than 50% reduction, less than 70, you can give antithrombotic therapy, and all these things should be done stepwise when you have a chronic coronary syndrome. So conclude my talk, secondary prevention in chronic coronary syndrome is crucial to reduce mortality and morbidity. High level of adherence to secondary preventive intervention include aggressive lifestyle changes, and appropriate pharmacotherapy can lead to a significant decline in recurrent coronary event. Physician and patient level intervention are important to promote lifelong adherence to these strategies, and more adaptation of digital healthcare system may improve these adherence. Thank you very much for your kind attention.